Good evening and welcome to our virtual program, How to Talk About Puberty and Body Image. We are very grateful to have Doctors Heather Appelbaum and Jennifer Northridge with us tonight. A little bit about our speakers. Dr. Heather Appelbaum is the Director of Pediatric and Adolescent Gynecology for Hovnanian's Children's Hospital at Jersey Shore University Medical Center. She is also the Associate Professor of Obstetrics and Gynecology at the Hackensack Meridian School of Medicine. Her office is located in Oakhurst. With more than 20 years of experience, Dr. Appelbaum specializes in minimally invasive gynecological surgery for children and adolescents and pediatric pelvic reconstructive surgery. Her special interests include congenital anomalies of the reproductive tract, vaginal adnexes, disorder of sex development, ovarian cysts, ovarian torsions, genital trauma, endometriosis, polycystic ovarian syndrome, abnormal female pubertal development, and menstrual disorders. She has numerous publications in the area of pediatric and adolescent gynecology, lecturing locally and nationally on these topics, and she has served on several national and local medical advisory boards and has developed and participated in multidisciplinary programs for patients with disorders of sex development. Dr. Jennifer Northridge is an adolescent medicine pediatric specialist. She graduated cum laude from Williams College. She earned her medical degree with a distinction in research from Mount Sinai School of Medicine and completed her pediatric residency at New York Presbyterian Hospital, Weill Cornell Medical Center, followed by a fellowship in adolescent medicine at the Children's Hospital at Montefiore Albert Einstein College of Medicine in New York. During her fellowship, she conducted clinical research focused primarily on healthy relationships in adolescent gynecology and has presented nationally regarding eating disorders in adolescents. Dr. Northridge is the section chief of adolescent medicine within the Department of Pediatrics at Hackensack Meridian Health and an associate professor of pediatrics at the Hackensack Meridian School of Medicine. She provides consultations for teens and young adults ages 12 to 21 in adolescent gynecology, menstrual disorders, and eating disorders. So at this time, I will turn it over to Dr. Appelbaum.
Good evening, everybody, and thank you so much for joining us tonight. I want to applaud all of you for participating in this webinar because it shows that you really care about your children and you want to learn the best way to educate them and educate yourselves so that your children can grow up healthy and understanding the facts. So I'm going to get started with our first slide today. This is this is not our first slide. So Dr. Northridge actually is managing the slides from a virtual distance. So I'm going to give her a little bit of like thumbs up. Let's go to the next slide each time we need a new slide. So we're going to start just with the definition of puberty. And I think it's important to know that puberty is really, that occurs over a period of time. And it's marked by physical, cognitive, emotional, and social differences that happen as the children progress from the stage of being a child into the stage of being an adolescent. And there's some significant transformations that occur during this time period. Thumbs up, Dr. Northridge. Okay, and so there is some significant biological and physiological things that happen during the time of puberty. And from that biologic and physiologic standpoint, signals begin to develop in the brain, and they produce certain hormones that then stimulate the ovaries in girls. And the result is a coordinated symphony of hormones coming from the brain that stimulate the ovary, and then hormones coming from the ovary that then stimulates the uterus and the uterine lining to then produce a period. But a lot is occurring at the same time. And it's very important that these hormones work together, which is why I call them a symphony, because if one hormone is off, it's like having one instrument off in the menstrual cycle or in the symphony, if you will, and things start going awry. So we hope that things are going to be nicely coordinated and that one thing will affect the other and we'll have a coordinated effort to allow for the menstrual cycle to begin. So if Dr. Northridge, if you can advance the slide, we'll talk about some of the physical changes that occur during puberty. For girls in particular, the changes that occur is that most of the girls will have their first onset of breast development as the first sign of puberty starting. And that occurs at an average age of approximately 8 years to 9 years of age. And that's on the average. And then shortly thereafter, we'll see with the breast enlargement that the labia or the lips, the labia and the vulvar area start to extend and grow. And they may grow beyond the distance of the labia majora, and so that the inner lips become elongated. And typically, girls will start to develop pubic hair about 6 months after the onset of the initiation of breast development. And then the average age of the onset of the first period is between 12 and 13. And so what I've now described for you is that puberty is a process and occurs over the course of several years that starts with breast development and carries its way through all the different changes that the body goes through. And the period is not actually the first sign of puberty, but it's one of the last signs of puberty. And it occurs over approximately a 2-year span. In boys, Dr. Northridge, you can advance me now. In boys, puberty begins with thinning of the scrotal skin and testicular enlargement at the average age of 11.6. Subsequently, and after that, the penis begins to enlarge and initially starts to lengthen. So it enlarges in length first and then width thereafter. And hair starts to grow, typically about 6 months after the onset of the activation of both the hypothalamic pituitary ovarian axis, which begins in the brain and works its way through the gonads, and also simultaneously the adrenal glands will develop, and therefore the boys will start to develop hair under the arms and pubic hair. And both in boys and girls, the sweat glands will start to be stimulated by these hormones, resulting in body odor. And so we can advance to the next slide. So now that we understand what happens during puberty, both in boys and in girls, now, obviously I'm a gynecologist, so I specialize in girls, so I'm going to primarily speak about girls today. But I think the concept of how and when to have the talk with your children is the same, whether it's the boys or the girls. And the content might be slightly different, but the bottom line is that the children need to understand that their bodies are going to go through changes. And I think the biggest question that everybody has is not only how to have that talk, but when to have that talk and when to start that conversation. And my recommendation is that you start that conversation early. And what I mean by early is because once the children start to develop, they're going to have all sorts of questions. And if you've answered them ahead of time, then the kids are going to be prepared for those changes that are going to occur in the body. And rather than being scared or frightened by them, they'll be expecting them. And I think that one of the biggest things that we want to avoid is a fear of the unknown. A fear in the unknown of our children creates anxiety. But when they have knowledge, as you know, knowledge is power. And we want them to understand the facts. We don't want them to hear things from their friends or hear things on their street that may or may not be accurate or may not be comprehensive, that may not explain everything the way it is supposed to be, or in the order it's supposed to occur, or in the right context with which it's supposed to occur. And so I would encourage you to start the conversation before you think your child is going to develop. And I might even add that there may be some benefit in starting that conversation prior to the first kid in the class developing, or at the time when the first kid in the class develops. Now, somebody needs to be the first child in the class, somebody is going to end up being the last child in the class, and most likely your child's going to be somewhere in between, but you could be the first and you could be the last. But under the assumption that your child is going to be somewhere in between, if you start having that talk when the first child starts to show signs of pubertal development, then you will have initiated that conversation prior to your child changing and prior to him or her finding out information from that child who started developing before them. So if the children in the class are starting to develop at the age of 8, and your child is still a small child, has not gone through a growth spurt, you haven't seen any changes, 8 is not too young. It's actually very accurate in terms of the timing. I would also encourage you that when you have that conversation, to use the correct terminology of the body parts, of the things that are happening to the body, because this is the way our child starts to learn information. And if we start to use nicknames or slang terms, the child, first of all, may not understand what they're talking about, because there's no universal language except for the correct terminology. And if they need to talk to another adult or they need to talk to a doctor, they may not be able to express themselves in a way that they can make themselves understood if they don't understand the correct terminology. So it's very important to label the body parts as they're supposed to be labeled, and label the physiologic functioning of the body the way it's supposed to be labeled, as opposed to couching it in, I would say, baby talk or slang talk. The other thing I want to just touch on is that I think that people get overwhelmed, or parents can get overwhelmed with the concept of trying to have the talk with their children, because they don't really know where to start that conversation, and they don't really know where to stop that conversation. And I would encourage you to realize that you know everything, but just because you know everything doesn't mean that you have to give all that information to your child at one time. You need to give the information that you think is important for them to get through the period of time that they're at, or the stage that they're at right now. And you can give a stepwise disclosure of information. So just because you're discussing periods doesn't necessarily need to mean that you have to have the sex talk at the same time. I think it's important for the kids to understand that their bodies are changing. And you may address a girl in terms of the girl physiology and the girl parts, and a boy in terms of the boy physiology and the boy parts. And maybe a later conversation will include what the opposite sex is doing. And maybe even a further later conversation will include pregnancy, fertilization, sex, babies, and all that other talk. So you really do not have to be overwhelmed with the first conversation. Once you get started, you'll see, depending on how much your child is able to absorb and what their developmental level is of, and their ability and capability of understanding intellectually what you're talking about. And that will dictate how much you disclose on the first conversation and how many things you need to talk about. I do think you need to have a rudimentary or basic understanding of the facts so that you can provide the information in a basic format and prevent fear of the unknown and avoid miscommunications. However, this doesn't have to be a long and involved and detailed conversation, because you want to open the conversation for discussion and allow for your children a window in so that they can ask you questions. So if you give some basic information, you have a very inquisitive child who's going to ask lots of questions, I would encourage you to answer them, but you should answer them in an age-appropriate fashion. And you can use yourself as a role model when you have the conversation with your children. You've developed from a child at one point, and you've become an adult, and your body went through the same transition that the child is going to go through also. And so if you use yourself as an example, I think it instills a level of comfort in the kids so that they know that they're not the only ones who are experiencing this type of change in their body. And I think it's very important to reassure the kids that curiosity is okay, that there is no question that shouldn't be asked, and there is no question that you as a parent or the guardian will not be willing to answer, as long as the conversation takes place in private. And I like to encourage the kids to have these conversations as much as they feel comfortable and as frequently as they want to, as long as it's not what I call bathroom talk or lunchroom talk. This is talk that's meant to be intimate between somebody who cares about the child and who's going to help them transition to this important phase of their lives. Okay, next slide, Dr. Northridge. Thank you. Okay, so just so that we all have the same facts, and that is that the average age of the onset of puberty, excuse me, begins around the age of 10. Now, there's a window that occurs somewhere between the age of 8 and 13, and it's still considered to be normal. And no two children are the same in terms of when they're going to develop. And there really is no predictability as to when a child is going to start the pubertal process. But we do know that the pubertal process typically begins with breast development. And after the breasts start to develop, the next thing that we typically see is a growth spurt. And so that a child will go through a rapid growth spurt. And then shortly thereafter, the pubic hair will start to develop. And that also includes hair under the arm. We have additional growth that occurs. And then 2 years after the onset of the first sign of breast development is typically when the first period will occur. And the average age of that first period is between the ages of 9 and 15 or 10 and 15. And breast development will continue to occur. The pubic hair will continue to fill out. And then typically the pubertal process is completed within 2 or 3 years. Next slide, please. As these things are occurring, different things are happening in the body. And they occur at the time of puberty as the first presentation, but then for a girl who is cycling on a regular basis, on a monthly basis, she may have one or more or none of these symptoms occurring just before she gets her period. And that includes bloating, food cravings, cramping, body odor, changes in the breast size or the labial size, headaches, acne, changes in her mood or irritability, gaining weight, and like I said, food cravings. And these things are a normal part of the pubertal process and a normal part of the menstrual cycle. Can you go to the next slide, please? And the other things that are normal that I want you to have kind of in your back pocket so that you can explain to your children is that the age of onset of the first period, like I said, should be somewhere between the ages of 9 and 15, and that the periods occur on the average of every 23 to 35 days. Now, I don't like to say that it occurs once a month because different months are different days, have different lengths of days, right? So we have in February 28 days, and we have in other months, we have 31 days, right? So we don't want to say that it occurs on a monthly basis, because if a girl is getting her period every 25 days, then she's going to get her period twice a month. And I don't want anyone to be concerned that they're getting their period at the beginning of the month and the end of the month, because that might be normal. And when we count how long a period is, we count from the beginning of one period to the beginning of the other. And that's the length of a cycle. And that's what should be between 23 and 35 days. Whereas the duration of the bleeding typically should be somewhere between 5 and 7 days. And it's very normal to change a pad or a tampon every 2 to 4 hours on the average. And these are the normal parameters. Let's go on to the next slide. Because adolescents don't typically follow the rules, right? They don't follow the rules in every case, but particularly when it comes to the menstrual cycle. So most girls will have irregular cycles for up to 2 years from the onset of the first period. And what I mean by that is that they may not follow that typical every 23 to 35 days. They may skip a month. They may even skip 2 months. They may not have a cycle for even 4 months. But beyond 4 months, I think we need to evaluate that situation. But it is very typical for them not to have a cycle on a regular basis. And some girls might even have cycles that are too frequent, that occur more frequently than every 23 days. In that case, we need to make sure that they're not bleeding too much and becoming anemic. However, some level of unpredictability is typical and normal. And after the first 2 years, about 2/3 of the girls will start to develop regular cycles, but that leaves 1/3 that are still having non-cyclic, unpredictable bleeding that may be of an inconsistent volume. And they may have short cycles and they may have long cycles. So that's a lot of information and hard to decipher out what is considered to be normal and what's considered not to be normal. But we're going to go on to the next slide so I can go over with you what falls outside the range of normal. So when a girl has not gotten her first period by the age of 15, we usually recommend an evaluation. Or a girl who starts bleeding before the age of 8 years. That's considered to be early and also would be worthy of an evaluation by a gynecologist. For a girl who's not having a period for more than 3 or 4 months, that's also a sign that we need to explore things further. And the reason is because we consider the menstrual cycle to be what's called a vital sign. I think you all know the vital signs when you go to the doctor, where we check the pulse, we check the blood pressure, maybe we even check the temperature. And the reason that we're doing that is because we're trying to get an overall understanding of the health of the individual patient. And just because somebody's heart rate is high, it doesn't mean they're having a heart attack per se, but it alerts the doctor that they need to explore further, that there may be something wrong or something that's going on. And so the same is true for a girl who's supposed to be menstruating on a monthly basis. If she is not getting a period at least once every 3 months, or she's getting a period more frequently than every couple weeks, or she's bleeding for more than 7 days each month, it's a sign to us that maybe something else is going on from a systemic perspective, and that child needs a further evaluation to see what the cause is, why their monthly cycle is not regular and predictable. Another reason that girls may come to see the gynecologist is because they have pelvic pain. Now, I told you that cramping is very normal, and we expect that to happen right before the menstrual cycle, maybe even during the period. And there's a huge range of what's normal. But I use the parameter generally is that if a girl is not able to go about her daily business, meaning she's not be able to attend school, she needs to come home from school, or it is that she's not able to engage in her recreational activities or social events with friends, then that's probably outside the range of normal. And really I think is a good reason to see a gynecologist, because nobody should be debilitated by their pain that's associated with the menstrual cycle. When we get our period, when girls get their period, this is not a disease state. This is not a girl who's sick, and a girl should be able to function in her regular daily activities without compromise. And anything that compromises her ability to behave like a regular girl when she has her period is outside the range of normal. No girl should be having to suffer as a result of her period. Also, having discharge may be normal, but discharge that's odorous, that has a smell to it, or is associated with itching is not considered to be normal. And it's worthy of a trip to the gynecologist to go over maybe personal hygiene, make sure that there isn't any sort of infection, and to do an evaluation. Other reasons that girls come to see the gynecologist is because they may have a genital injury. And as we approach the summer months right now, and girls become more active in sports or on the playground, unfortunately, we see genital injuries more frequently. But the good news is that gynecologists can take care of these things. We also see girls when they start to engage in high-risk sexual behaviors or regular sexual behaviors. You know, this is a talk about young adolescents and preteens and tweens, and hopefully they're not engaging yet in sexual activity, but some of them are engaging in sexual activity at an early age. And we want to make sure that if they're engaging in sexual activity, that we're preventing sexually transmitted infections, and that the girls are educated to know that they can develop sexually transmitted infections even without having penetrating intercourse, but just by the sheer nature of engaging in sexual activity. And this is not unique for girls who are heterosexual. This is true whether their sexual orientation is to the same sex or to the opposite sex or to both. And so it's not unique to any patient population, but we do need to make sure that patients are very well educated and know how to prevent sexually transmitted infections, and that they're using contraception when we don't want, and so that we're preventing unwanted pregnancies. But more importantly, and maybe or equally importantly, that they're not putting themselves in high-risk situations where they may be at risk for sexual assault, either by somebody that they know or don't know. And so that's going to bring me to my last portion of this conversation tonight of what I'm going to be talking about. And I'm going to ask Dr. Northridge to advance to the next slide, where we're going to talk about teaching your children about being a self-advocate for their own bodies, that they are the boss of their own bodies, and that it is not okay for anybody to touch them in any sort of way without their permission. including the doctor. And so hopefully the girls, if they need to see the doctor, will give the doctor permission, or it'll be in the presence of a parent or guardian who is making sure that that there is somebody advocating for the child, even at the doctor. But what you really want to be teaching your child is that it is not okay for someone to touch your private body parts unless you say it's okay. Nobody, not a family member, not a friend, and not the doctor either. And it is not okay to touch somebody else's private parts. You can't just take your hand and touch whatever you want to. That's not okay touch. And it is not okay for someone to touch their own body parts in front of you. And the same way it's not okay for you as a person to touch your private parts in front of someone else. Those are private behaviors that should be done in the privacy of a person's own bedroom. It is not okay for someone to ask you to take your clothes off. And you might assume, and you might know that that's obvious and intuitive, but guess what? It may not be intuitive or obvious to our children. And just the same way we teach our children about stranger danger when they're at a stage before this, and we teach it to them over and over again, because we assume that they forget, or we assume that the more we tell them, the more they're going to know. The same is true with these concepts. We can't assume that the children will remember or know that it's not okay to do some of these activities unless they're told over and over again. And in this day and age, it's also important to teach the children that it's not okay to take pictures or videos with your clothes off, or for someone else to show you pictures or videos with their clothes off. And the last thing I want to talk about is safe touch. Safe touch is touch that makes us feel cared for and loved. For example, safe touch is a hug or a pat on the back, maybe a high five, maybe even a kiss on the cheek, or even safe touch can be something not necessarily that feels good, but something that might feel bad, but still is considered to be safe, like removing a splinter or when the doctor does an examination. So we shouldn't confuse safe touch with touch that feels good, but it's touch that's to our benefit and may feel good and may make us feel like we're loved or cared for. As opposed to, on the flip side, unsafe touch, touch that hurts, touch that doesn't feel good also, but even if it does feel good, it's not safe touch. Something like hitting or pushing or pinching or kicking. I think that's intuitive to all of us as adults, but may not necessarily be intuitive to children. And it's important to outline the difference between safe touch, unsafe touch, that hurts, that may be obvious, and unwanted touch, because unwanted touch may be touch that actually may be good touch, but doesn't feel good or isn't wanted at the time that it's occurring. So hugging from a parent might be considered to be safe touch. It may be considered to be good touch, but when you get hugged by a stranger, maybe that's unwanted touch. And unwanted touch is not okay. It's touch that might be safe, but isn't desired. And it's a subtle difference, because we don't want our kids thinking that just because they're being touched in a way that's maybe considered in context to be okay in one scenario, that it's not okay in another scenario. And so that they should be self-advocates. And if they don't want to be touched, even if it's by a parent or a loved one, it's okay to say, I don't want to kiss right now. I don't want to hug right now. I don't feel like I want to high five. I don't want to be touched, whether it's in a scenario where they know the person touching or they don't know the scenario of the person touching. So with that, I'm going to turn over not only the movement of the slides to Dr. Northridge, but the talk to Dr. Northridge. And I will be available at the end to answer any questions relevant to the presentation that I've made to you tonight.
Thank you so much, Dr. Appelbaum. Building off of what Dr. Appelbaum was talking about, when talking about teaching about sexuality, there are some additional resources we wanted to make sure that we shared with you for adolescents with autism. So Autism Speaks has amazing resources to use that parents can use, that their ABAs, behavioralists can use, talking about appropriate public behaviors, and there's pictures to go along with this, and private behaviors like in bedrooms and bathrooms, and go through with pictures about what's private parts, like areas covered by underwear, and how in public we don't touch our private parts. And instead, if we have urges, we keep our hands by our side or fold our hands. And it's just really helpful resources that I've used with my patients in conjunction with the developmental pediatricians at Hackensack. In talking about just overall puberty, Dr. Appelbaum did a wonderful job talking about a lot of the physical changes. And now I'm going to touch upon some of the cognitive changes that happen during puberty. In early adolescence, they're still very concrete thinking, and that adolescents are beginning to separate from their parents and identify with their peers. This is my 12-year-old boy right now. And then as they go through middle adolescence, our 14 to 17-year-olds or high school age adolescents start to be able to make more moral choices based on abstract values, and they can imagine future consequences of their actions. And this is the time period where peer influences really like peak. And then later adolescence, I joke in some ways that this is when adolescence becomes like, I obviously am an adolescent medicine doctor, so I like adolescents, but this is when they like be able to fully appreciate consequences of their actions, and they're really pleasant to be around, although I do like all adolescents. That's the cognitive. Then the social emotional changes. There's obviously this, in early adolescence, there's this beginning of like increasing independence with this focus on peers, less interest in parental activities, and a more reluctance to accept parental advice, right? I'm a doctor and my 12-year-old boy doesn't always want to like listen to my medical advice. That this emotional void created by separation with parents without the presence of like a good support group, good friends, can create behavioral problems. These days, obviously, peer relationships are complicated by social media, and that emotional ability, a lack of impulse control, and need for immediate gratification may result in risk-taking behavior, right? So emotionally, they haven't fully developed yet. And so it makes emotional like impulsivity more complicated at this age. And then in this time period, it's completely normal to have a need for greater privacy, closing doors in rooms, which is totally should be respected. Then in middle adolescence, right, this is like the peak of peer attachment. There also becomes this preoccupation on physical appearance. So while anorexia nervosa can start during early adolescence, the peak is during middle adolescence and this time period of a lot of preoccupation with physical appearance, which is hard based on all the physical changes Dr. Appelbaum already talked about. Right, this middle adolescence is this identity formation period with a sense of individuality, which adolescents might express through clothing, accessory, hairstyles. They start to develop abstract reasoning, and with this, a greater ability to empathize. And they do, though, still have this feeling of omnipotence and immortality that can be even like enhanced in the presence of their peers and can lead to accidents and high-risk behaviors. And then in late adolescence, right, like as our prefrontal cortex like fully is like connected to our hippocampus, we're able to think really more abstractly and do more future thinking. We've had identity separate from our family, and in that way, there's less conflict. Right, there is like this ability to delay gratification, and there tends to be this more like selective group of like close friends. Now we're going to shift from the physical, cognitive, social, emotional changes during puberty and talk a little bit about eating disorders for the last portion of our talk. And again, as we're going through, if questions come up, please put them in the chat. So I put this, who's at risk for eating disorders, a little tongue in cheek, because as someone who's taking care of adolescents with eating disorders, really everybody's at risk of eating disorders, that there's, right, this thought that being female puts you at increased risk. And that's true for anorexia nervosa, bulimia, although not all eating disorders like avoidant restrictive food intake disorder. And I think the important thing is to realize it can happen to everybody, because my male patients are the ones who come to me the latest. And part of that is just a lack of really considering eating disorders for boys also because they don't have periods, so it's not as obvious. That there is higher rates of eating disorders in LGBTQ youth. There is higher rates in adolescents who are obese. And those are actually some of my adolescents who are the hardest to treat because there's this real fear of weight gain because they were obese and some of them had health effects related to obesity. But I think it also highlights why it's important to talk about like healthy, sustainable lifestyles and a focus never to be like a number on a scale, because we want to have healthy, well-developed, emotionally, socially like adept adolescents, and the number on the scale isn't the most important part of their adolescence. So in terms of how parents can detect a body image issue, part of it is making sure that they see their pediatrician or primary care provider regularly, because especially for adolescents, sometimes there isn't a weight loss. There's just an inability to make expected gains, weight gains that we're supposed to make as we go through puberty and as we grow taller. Right, this is highlighting the exact same thing Dr. Appelbaum said, that like, right, knowing what your daughter's periods are, because periods are a vital sign. And if your daughter goes more than 3-4 months without a period, that's a signal to be in touch first with your primary care provider, your pediatrician, and potentially a gynecologist, whether that be a pediatric adolescent gynecologist like Dr. Appelbaum, who's OBGYN trained, or adolescent medicine provider like myself, who's pediatrics trained. Another red flag is if there's a lot of shape, weight, eating preoccupation, right? So I already talked about how in middle adolescence, it's normal to have a lot of like preoccupation with your appearance. But if you notice your teen is looking at the mirror constantly or avoiding mirrors completely, that could be a red flag. Also, right, you are the one who's like an expert in your child as a parent, and you're the one who's like fed your child. So you know a lot about what your child likes to eat. And so if you notice there's like these real changes, right, restriction in entire food groups, like new onset vegetarianism, it could be, right, based on all sorts of like moral, ethical issues, but it could be just a red flag for an eating disorder, and might warrant conversation with your pediatrician and one of us. If there's new food rituals, right? So like cutting food into very small pieces. And then particularly, right, eating has huge social impacts in it. So if they're no longer having family meals, if there's a lack of flexibility in eating out or eating with extended family, then that's concerning for an eating disorder. And obviously, if you're concerned that your child might be purging, even if you're unsure, it's reasonable to bring it up with your doctor or your child's therapist, if your child has a therapist. Concern about laxative use or concern about calorie counting. I will say I'm not a fan of like all these calorie counting apps or like this focus on macros that particularly for adolescents, they have increased nutritional needs as they go through all those physical changes Dr. Appelbaum talked about. And so they have more nutrition needs, and those calorie counting apps are particularly problematic and can lead to eating disorders. If you're concerned that your adolescent has body image concerns or an eating disorder, it's important to communicate with your pediatrician. You can talk to the school, especially if the school has a therapist. And it's important to help your child see through the other side of the eating disorder, right? You know your child best. And so often I think of it as a Venn diagram of different circles of your child and an eating disorder. And so it's important to remind your child of all the good stuff about them that's separate from their eating disorder. And then to put that in a more positive note, right? How to even like prevent an eating disorder from happening, because it can have huge consequences in terms of their physical health and emotional health. I think it's really important, right, that you as the parent, even as they're going through adolescence and peers become more important, that you are a huge role model for your children. So it's important to promote healthy relationship with food, Try to avoid labeling foods as good and bad. It is okay that some foods we have more sparingly than other foods, like vegetables, but we don't really want there to be good foods and bad foods. We want to have a variety of foods that are important for healthy development for adolescents, right? And in our role as a role model, right, to try to avoid saying comments like, oh, I really shouldn't have had that cookie, like it's okay to have cookies, and try to avoid saying comments about putting down your body. I think, right, one thing that goes along with this is celebrating all of your child's qualities, not just the physical ones. I try to be very mindful, and I'm guilty of this as well with my young daughter, that I call her, right, beautiful all the time. But I think, right, talking about how she's kind, celebrating, right, all these non-physical qualities is important in our children. Right. And then this emphasis on a healthy lifestyle, and not just about like weight on a scale, right? So physical activity should be fun. It shouldn't be about weight loss. It can be about like keeping our heart healthy, but ideally trying to help your adolescent finding physical activity that they find enjoyable, because that's really what will be sustainable. And ideally physical activity that's social and will help them have ways of social engagement that aren't centered around electronics or social media. And then, right, another thing as a parent that you can really help is encouraging your child to have clothes that fit and feel comfortable, right? So we all have had clothes that are a little too small, but particularly adolescents, as they're going through puberty, particularly, I know I have a bias that I see more girls than boys, although clearly I see boys for eating disorders, but girls, as they go through puberty, their percent body fat increases. So there really shouldn't be like an expectation that they would get back into some jeans that are too small for them, right? So to get rid of the clothes that are not their size and help them find clothes that they feel good in. I know we're already on our concluding slide. I'll talk about it. So I think just in conclusion, red flags to discuss with your pediatrician includes all those things about eating disorders. We also just wanted to touch upon like mood disorder concerns as well, right? In teenagers, depression often presents as irritability, right? So it isn't this classic, like, I'm so sad I can't get in bed. Sometimes it's just a lot of irritability. And while some level of irritability is normal in adolescents and is normal, right, in girls as part of like their premenstrual symptoms, that if there's like functional consequences to that, piggybacking on what Dr. Appelbaum said before, right? So if they're depressive symptoms, their irritability is getting rid of them socially, they're not hanging out with friends, getting in the way of them going to school, then that is concerning. Similarly for anxiety, right? If their anxiety is getting in the way of their functioning, then that's concerning and should be discussed with your doctor. And in like, right, again, part of the functioning is obviously school is our adolescent's job. So if they're doing worse in their job, if they're like declining in school performance, even if they're showing up, then that's concerning for a mood disorder, and in some cases substance use. And should certainly be discussed with your child's doctor, and might be a, right, if their functioning is in declining, then I think that's really a signal to consider therapy and or medication. All right, and then we just wanted to make sure we highlighted resources that you guys could use. These will also become available this presentation, but the American Academy of Pediatrics is an amazing resource to use. Bright Futures, in particular, through the American Academy of Pediatrics, talks through all the things we talked about today in terms of puberty. The American Academy of Pediatrics also has an entire thing about healthy relationships to help you talk with your teens about what a healthy relationship looks like, and talks through different mental health issues, including eating disorders, depression and anxiety, and substance use. I also included here the website for the National Eating Disorder Association. And then the last one is Autism Speaks, which has amazing guides for children with autism and developmental delays about talking through about puberty and sexuality and some of the specific things you might have to focus on for those adolescents. So I think right now we're going to open up to questions. If anybody has questions about what we've presented, to put it into the chat. I think Allison might come on and talk about some of the questions that have already been submitted.
Yes, thank you so much, Dr. Northridge and Appelbaum. That was very informative and a great presentation. So we have a few questions that were submitted ahead of time. And some of these may have already been covered, but how do you help your child lose weight? When should weight loss surgery be considered? And I guess, what is a healthy weight for an 11-year-old?
Great question. I'll start with it, and then Heather, if you have other things you want to add on. So I think the thing about being 11 is that you're still in puberty, right? So you're still likely, if you're a girl or a boy, going to be growing taller. Some of this obviously matters if you're a girl, if you've already had your puberty, if you're kind of like an early puberty person. But because they're still in puberty, often we don't need to lose that much weight. And in many cases, maintaining a weight is enough to get to a healthy BMI. So I think, right, when we think about why somebody might be at a higher weight, it's trying to also get to some of the underlying causes, right? So if there's an underlying mood disorder, then we have to focus on the underlying mood disorder. They won't get approved for any kind of weight loss surgery if there's an untreated eating disorder. I will say, just as a caveat, right, in order to have bariatric surgery, you have to be completed with puberty. So it's done in older adolescents, but somebody at the age of 11 would be too young for bariatric surgery. That sometimes you don't necessarily have to be 18 to be approved for bariatric surgery. There are, within our healthcare system, older adolescents who are sometimes approved, but you had to have like completed puberty. So I think, right, focusing on the underlying causes, if it's somebody who's always been overweight and obese, if it's something that happened more recently, if that more recent weight gain might be related to underlying depressive symptoms, if that more recent weight gain might be to underlying eating disorder, right? If there could be some binge eating disorder, then really targeting that is the most important thing. If it's related to sleep dysfunction, right? I think obviously if there's concern about weight gain, the first stop is your pediatrician or primary care provider. And then there are, right, pediatric endocrinologist multidisciplinary teams that would be the next place to go, right? Multidisciplinary programs that involve a pediatric endocrinologist, nutritionist, dietitian, and often like a physical therapist to help with increasing physical activity. Up north, it's called, the Hackensack is called, I know, of course, I'm not thinking, but Dr. Michelle Maresca runs the program through pediatric endocrinology that I'm blanking on the name of, but Maresca, M-A-R-E-S-C-A. And I know that there's a similar program down south. And I think that's the important place to start. And again, right, so then the focus would not be necessarily on weight loss, but having the whole family eat healthy, not making it like different for them, right? The whole family finding good varieties of foods, having your house filled with foods that, right, are good and nutritious for all of your children's development and for your own. And right, that might include really limiting sugary beverages in your home because it's not really of much nutrition value to any of us. Yeah, and then right, focusing on like exercise, trying to help find exercise that your child might enjoy. I think I hit on most of the points.
I think you did, Dr. Northridge. I think that was really comprehensive. And I just would like to re-emphasize that when we think about our children's weight, we have to think about, if we're going to approach it in any sort of way, what's our goal, right? Is our goal to keep our children healthy, which I think everybody would agree is the goal. And we have to prioritize our goals. So I think the first goal for these kids is to get them through puberty in a healthy way. And part of the pubertal process is the body is going through significant changes. And so it's not the ideal time to focus on weight unless somebody has some sort of eating disorder. Then we have to focus on the weight because they've chosen to focus on their weight. But us as adults, I would encourage you not to be too focused on it at this time period in this segment of development, because like Dr. Northridge explained, the children have to grow. We expect them to grow in height. And with the grow in height, there should be a proportional growth in weight, so that if it's disproportionate, then it's the equivalent of if somebody's growing taller and staying the same in terms of their weight, it's as if they effectively lost weight, right? Because there's a differential and we expect them to grow proportionally. And so I don't think it's the ideal time for us to focus on weight loss. Now, if we have kids that are starting out overweight and entering puberty that way, what we really can do is encourage healthy lifestyle habits that are going to carry them on through their adolescence and into adulthood. And that is, that is always a good way to emphasize things as the body is going through the changes during puberty, to emphasize healthy eating 3 meals a day with some snacks in between is very healthy. So the frequency with which we eat, the food choices that we make, like Dr. Northridge said, not allowing or not emphasizing empty calories. And the other part of it is, are we eating the right quantity? Are we overeating? Are we undereating? So you can encourage the healthy eating habits without trying to particularly focus on body habitus and weight loss. And that, I think, will encourage our children to have a healthy attitude to what they're putting into their bodies and how their bodies are as a result of our healthy behaviors, as opposed to focusing just on the appearance or the optics of how the child looks. And the other part of it that Dr. Northridge said, and I would just emphasize a little bit further, is also healthy activity. We don't want to have our children over-exercising to the point where they're, let's say, purging their calories by exercising, but we do want them to keep moving. So kids that are, couch potatoes or just, on their cell phones are certainly not encouraging a healthy metabolism. And so you can encourage healthy activity. And that, I think, is far better and far more important for you to focus your energy on than on particularly weight loss, because weight loss, if it's intended, will naturally follow suit if we have healthy eating habits and healthy activity and exercise habits.
All right, great. The next question, what is the best age to have the talk with your child?
So I think that that kind of lends itself to the beginning of my talk, which is, when is the best age? And I really like to use that parameter of, when is the first kid in the class starting to show signs of development? And that's the window of opportunity. That's the best window of opportunity, because once that child starts developing, everybody start asking questions. And we want to instill in our kids the armamentarium and the toolbox to have the right answers and talk the right talk and have the right lingo and have the right understanding of what is happening, not only to themselves, but what's happening to the peers around them. And a healthy attitude that there's a huge variation in what's considered to be normal. And so that just because one child in the class is developing doesn't mean that you're abnormal if you're not doing it on the same time frame and the same spectrum that they are, that there's a huge variation, and that's okay.
Yeah, agreed. I think that, right, as having a 12-year-old boy right now, like, things organically come up sometimes as we're even like watching movies together, right? Sometimes things are shown and then you can like talk about it afterwards. And I think in terms of healthy relationships right now, he's not dating. I'm gonna have to like take my own medicine as an adolescent medicine doctor as I get an adolescent. But right, like right now, in terms of like seeing what healthy relationships are and how he navigates his friendship relationships, and we talk about like what respect is, right? What like a healthy relationship looks like. I think that helps when you talk about that in a friendship context before a romantic context. Because I think one of the biggest things I've learned as an adolescent medicine doctor is that adolescents don't necessarily know what a healthy relationship is. And we like, right, as a doctor, I can only do so much, but you as the parents are really the ones who are going to help teach them what healthy relationships are. And obviously the talk about sex is within that context of what healthy relationships look like.
All right, thank you. And it's time for one more question. And it's how to build self-confidence in children as they go through school. Any particular tips?
Dr. Northridge, I think that's your question.
Yeah.
You are the specialist.
Yeah. So I tried to talk a little bit. I had like a focus on like great body positivity, but I think some of those things about being a role model is translatable to like how to build self-confidence, right? So I think that focusing on your children's like strengths is really important, right? And not right, focusing on what they're not doing well, and right, not focusing just on like physical appearance. I think that in order to build self-confidence, it's important to have time with your children and have time with your children away from screens. So going on family walks, right, having time where you like force them, having family dinner. I must say my family dinner got very shortened today, so I'm not like a perfect family dinner person, but like I do value that time when I do have it. I think those things are really important. And I think, right, part of that is building resilience, right? That what we want the most for our adolescents is resilience. Not necessarily like perfect scores at school, but to give them like positive affirmation for trying, for working through it, to getting through hard assignments, positive affirmations for treating their friends like in a good ways, even though they're right figuring out like friendship stuff as they go through middle school. And so I think some of it is really about the process and building resilience as opposed to just being like performance based, like just giving right, like ice cream for A's or things like that.
All right. Well, thank you again, Dr. Appelbaum and Northridge. Your presentation was excellent. You provided so much helpful information. And I just want to thank everyone for taking the time tonight to join us. Please watch your email for an evaluation of the program. Please take time to fill it out. We want to hear from you, and also let us know if there's other topics of interest. We will share the link of the recording as well. We have several other parent forum webinars that are being planned. So please visit our website at hackensackmeridian.org to find out more information about these upcoming programs. So again, I thank you all for participating in tonight's program, and I hope you enjoy the rest of your evening. Take care.
Night.